All right. Well, thank you for coming back after lunch. I know it's a long day. I'm going to talk a little bit about oxygen now before doing some more demonstration. Just out of interest, does anyone use closed loop oxygen control? Kieran, anyone else? No? So I think it is a mode that's now on most of the ventilators, but we probably, or a function on most of the ventilators. I should say it's not a mode, it's a function. We probably are all trying to work out what to do with it a little bit. So I'm just going to walk through that. And I'll just declare for this one that I'm involved in a trial of closed loop oxygen in term babies and bronchiolitis, which SLE provided the ventilator for. We did the trial with the inventor of the algorithm for the Oxygenie, which was Peter Dargaville. So remember that oxygen therapy in the NICU is something that we always struggle with, isn't it? It always causes much discussion. So it is the most prescribed drug used in the NICU, even more than caffeine and penicillin. We've known since the early 50s, since after World War II, that oxygen is essential for survival in babies, but that the wrong amount of oxygen can cause harm. And particularly the period of time from the 50s through to the 70s where there was a lot of to and froing over whether to have a baby on or not on oxygen and the association between retinopathy and prematurity. And I think many of you know that for many years there were quite a few babies that were harmed in one way or another because of our practice. What we don't really know is why is high and low oxygen biologically unsafe for a patient, particularly a preterm baby. Compounding this understanding that probably too much oxygen is bad for you and too little oxygen is bad for you is the difficulty in how we know what a patient's oxygen is, because clearly we're interested in either arterial or alveolar or cerebral PaO2. We directly influence that by a decision around how much oxygen we provide to a patient, FiO2. And then we want to know that if we make a decision around FiO2 and we change our PaO2, whether that change is good or bad. So hence we need a feedback system. So a way of actually telling us that our drug therapy change, our dose change, has had an impact on what we're interested in. And that thing we're interested in is PaO2, but we don't measure that. We measure SpO2, which is the saturation of oxygen in the peripheral tissue, not in the central tissue as well. It is not PaO2. And, as every medical student knows and generally learns to hate, because we all hated this as medical students, the relationship between oxygen saturation and PaO2 is not linear. So if you increase your PaO2, you don't get the same increase in your saturation. It's this sigmoidal curve, and we all know that that curve changes. We can change it with acidosis, altitude, temperature, and all sorts of things. So depending on where you are, if we are oxygenating in this part of the curve, small changes in oxygen saturations may reflect very large changes in PaO2. But up here, small changes in oxygen saturation reflect virtually no change in PaO2. So there's a limitation with the mechanism of measuring PaO2, and there's a limitation in the assumption that SpO2 is always equal to PaO2 or the right PaO2. There's other factors in place. So we have some difficulties there. We also have difficulties in that we know that SpO2 is changing all the time. It's not a stable measurement like many of the other things we measure, like temperature and so forth. So there's been a lot of work not on the FO2 that we should be exposed to, but the oxygen saturation range. And we spend a lot of time debating this, right? And generally most NICU ward rounds go around and start saying, why did that baby in 100% saturations overnight? They shouldn't be, and all of these sort of problems. We've had a series of large clinical trials that randomise babies from early life to a high range of saturations and a low range of saturations. And I think probably most of us would not say that's a high range of saturations. It's probably what we were already doing beforehand. about 91 to 95 or 90 to 94 or 92 to 96. So it's sort of fairly close, right? And there was just some data that came out from Boost 1 a long time ago suggesting that maybe a lower range of saturations might be favourable for people. And there's some biological rationale for exposing preterm babies to lower saturations early, because we know that they often are exposed to lower saturations developmentally in the fetus. So these 3 large randomised controlled trials, or it was really 4, one was divided in 2, all completed at roughly the same time. And when they all started, they all agreed to share their data, which meant that we ended up with one large trial, which was called the NeoProm trial, which recruited almost 5,000 babies and randomised them to these 2 approaches. And they found that the higher saturation range resulted in slightly less death or major disability, I think, as most of you know, but that was not statistically significant. It was almost 2% difference when that crossed, with the confidence intervals crossing 0. Interestingly, though, death was lower in the higher oxygen saturation range. Again, not a huge difference, but it was a statistically significant difference. And I guess for many of us, death is probably an outcome measure that you would accept. Small differences are probably important. And major disability was roughly the same in all of these. There was some problems with these trials, I think, as many of you know, that for all of the trials, the way they were conducted was the baby was not randomised to a higher or lower saturation range. Actually, they were randomised to a saturation monitor, and that every baby was on the targeted same range, and that the monitor was manipulated by the manufacturer to offset so that the babies in the lower range, it looked like they were in the higher range, and so that they all had the same thing. So you targeted the 91 to 95 in every baby, but for some of them, actually, if you saw 91, it would really be 85, if that made sense. And it was about halfway through these trials that they realised there was a problem in that algorithm, and there was an issue with the trial design. They changed the monitors and continued the trial, and they did show differences depending on which algorithm was used, which was a problem because it was a very large trial. When it came to secondary outcomes, some of them favoured a lower saturation range. So need for supplementary oxygen at 36 weeks was less in the babies targeting a lower range, which makes sense because that's how we generally wean them off oxygen. But more importantly, severe ROP was less, whilst in the higher saturation range, death and severe NEC were statistically significant in the higher range. So we have a problem where overall the BPD death combined outcome was no different. BPD outcomes aren't particularly different. But what we ended up with clear evidence that if we have a lower saturation range, we get more eye disease, and if we have we get less eye disease but more death, and if we have a higher saturation range, we may get more death and less eye disease. So as a clinician, we need to decide on which we think is the safest one to do. And I think most of us have said, well, ROP is quite an infrequent event, and it's got a treatment. It's very hard to treat death. So for many of us, I think we have come to the end of this saying that ideally we should be targeting a saturation range probably in the low 90s, 91 to 95. And is that the case for most of you? You're using that range? I hear some people will use 90 to 94, 95, some 92 to 96, but we've all ended up around the same. Is that right? Does anyone target saturations in the 80s? No. Yeah. So that's all very good. So we've got evidence. We've got clear evidence basis here. Some of that evidence is a little bit woolly and a little bit blurry because of the problem with the saturation probes in the study. But we've got at least an evidence, and most of us have come to a very comfortable place that this is what we should do. The difficulty is it's easy for us to sit around a table like this and say, there's the evidence, this is the right thing. Now we have to implement that. And implementing evidence and implementing science is not as easy as it sounds. And that becomes particularly clear when you look at oxygen saturation targeting. And this is the trial data published by each of the trials where they presented their curves of oxygen ranges and incidence for each of the saturations the babies had in their trial. And what you can see when you look at the support trial on the top left there is I've highlighted in red and blue where the baby should have been. You don't expect the line to be a straight line. It should be a normal distribution curve. But you can see in the support range that they were pretty good at putting the babies in the high range, but actually in the low range, most of the babies were effectively in the high range. And the boost trial, which is on the right, shows that the algorithm did make an effect. You have this very funny picture when you looked at the old algorithm that had a fault in it, and then when you looked at the new algorithm, and I apologise, I've done the colours the wrong way around there, you got some treatment separation, but it still was nowhere near where they were meant to be. And it was actually the COT trial that probably got the closest to treatment separation between the two arms. But what this is telling us is that actually, even in a randomised trial where everyone, the nurses and doctors, knew the baby was in these important, massive trials, like huge, we're talking thousands of babies, people struggled to keep the saturations in the range. So it's a bit like saying, I want my baby to be on penicillin for group B strep. I'm kind of okay. You can give like 5 mgs per kilo or 60 mgs per kilo, and we'll see what happens at the end. So we wouldn't expect that. We wouldn't allow that for a drug like antibiotics, but it happens with oxygen. And it's telling us, it's not that the people doing these trials were incompetent. The nurses are really competent. It's just really hard to do because it's changing all the time and you've got a lot to do in your day. And this is some work out of Hobart where they looked, again, where the clinicians knew that they were being measured. And they were told that they wanted to keep the babies between 88 and 92%. And this was, again, it's sort of this was probably in Australia where most people were targeting before all the big neoprom studies, before we moved to a higher range. And you can see here this histogram, which you'll see a lot on this slide, which after the end of the study, they then downloaded where all the saturations from the babies and showed the frequency of saturations and the proportion of time there. And you could see that they were only in the desired range for about a third of the time. So a third of the time of babies had their saturations where they were meant to be. They spent more time hyperoxic than they did normoxic and less time hypoxic than they did normoxic, which probably is what we'd all expect because generally we're more worried about hypoxia than hyperoxia, and if in doubt, you'll tend to push the saturations up. That's just normal human behaviour. And as I said, twice as likely to be outside of target range. An interesting component of this study was then looking at human factors, and I think this is really important when we think about things like closed-loop oxygen, which was you are more likely to be in target range if you had one-to-one nursing. And you are more likely to be in target range if you had experienced nurses. So this is showing us that we can put the evidence from the trials in a slide and talk about it, or a New England paper, but implementing it actually requires a lot of different factors and requires nursing staff who know what they're doing. And I just want you to remember that when we go through this presentation and get to the end, because I think this is an important factor about closed-loop oxygen, that if you work in a unit where you've got one-to-one nurses and all your nurses have had 15 years experience trained after ventilated babies, you may well find that it's a different kettle of fish compared to a unit where you might have a baby in special care with one nurse to 6 babies and they're trying to juggle a whole lot of things. So this is a sort of a standard approach of what happens in ICU for most things. We have something we wish to give to a patient. So in this case, oxygen. That's called an intervention. And this is a closed loop system. So you have intervention, and in this case, we use an FO2 blender to develop that intervention. We change our FO2, we change our intervention. We want to measure something in our population, our outcome, which is in this case our baby, and in this case it'll be PaO2 or oxygen saturation. We need to have a way to measure that to know if it works. So in this case, we use an oximeter. And that oximeter then feeds back information to a controller, or who then has to cognitively decide, based on the information given and the intervention that was provided, whether a change is needed. And currently that's generally done by a member of a healthcare staff, so a nurse or a respiratory therapist or a doctor. But the closed loop oxygen says, well, why don't we change the healthcare staff to a computer chip in a computer in the ventilator, right? And it's very similar to what happens with volume targeted ventilation or volume guarantee. you are handing over the changing of the PIP to the ventilator instead of you and your nursing staff. And the rationale is that the ventilator has less things to do in its day and it's a robot, so it's only thinking about one thing. It's not worrying what's happening in the rest of the world, so it can make lots of decisions frequently and just focus on that one thing. We make lots of decisions frequently, but we have to do it over lots of different things. So it's more likely that if one thing does one thing only, it'll be more accurate. And that's the premise behind this, that if you hand over SpO2 control to FO2 control to the ventilator, ideally it's able to think and adjust more often than we will because we're not getting distracted by other things. And here you can see some plots over time of in the top, you can see oxygen saturations of each of these graphs. That's the dark grey bit. And in the grey sort of bar between the black lines, you can see the target. And at the bottom, you can see FO2. And in the left, you can see manual control. And you can see the oxygen saturations are fluctuating quite a bit. And there's been very few changes in FO2 because the clinicians had to come and do it. With automated control, you can again see that the oxygen saturations are fluctuating quite a lot. But what you're seeing, which is what you'd expect, because it's the patient that controls these fluctuations. But what you can see in the bottom is you can see that the FO2 is changing much more frequently than it would if it was a manual control. And that's the presumed benefit of the different closed-loop oxygen algorithms. This is data from Peter Dargaville, so with the Oxygenie. And in this study, which was one of their first studies with this algorithm, which they invented, you'll see the histogram here where the white bars are the percentage of time at each oxygen saturation with automated control, and the black one is with manual control, and these histograms are used for most of my slides now. And you can see there that there's more white bars in the target range in the middle and less white bars at either end of that normal distribution curve, implying that you have ended up with more time in target SpO2 range with the automated control on, probably because it was making more changes in oxygenation at the ventilator level. And that's the principle behind it. And this is what you see in clinical practice. Again, this is with the SLE one, the Oxygenie. So you can see here, this is a very chaotically breathing patient. And you can see here a plethysmograph. So just like on the monitor, you'll see an oxygen plethysmograph. You've got a PI index and a pulse rate there, as you'd expect to see. And then along the bottom here, you can see SpO2 chart over time. It only goes back 10 minutes. And you can see here is the target range that we've set. And when you set this up on this ventilator, you go in and you say, what target range do you want? And it gives you a few options. So here we've picked 91 to 95 because that's our default. You also pick, and this is very important, the upper and lower alarm limits. Because actually for the nursing staff, it's not your target range they're targeting, it's actually the alarm limits they're targeting. So, and that's very important. So you can see here the lower alarm limit set at 90%. And then in the bottom one here, you can see the trend of oxygen over time in FO2. And these are displayed here and here. And when you turn this on, it tells you what its sort of reference FO2 is. So if you put the baby on this when they're in 80% oxygen, it starts with a reference FO2 that's very high. If you put them on at 21 to 30% oxygen, it starts with a reference FO2 that's much lower. And that's sort of important for how quickly it will adapt to changes in saturation. So it tries to make some inference around how much it will allow saturations to fluctuate. And you can see here that at this point in time, the patient desaturated and the FO2 was turned up and went up to 85%. And then the patient started to oxygenate well, and you can see the FO2 has now started to drop quite quickly. And then as the patients become more stable, now in air and saturating well, you can see that the FO2's dropped considerably. For most of these algorithms, once you get to air, it turns off the upper limit because it can't do anything about it. So it can't target 95% when you're in air. So it goes to 100% at that point. So we have now quite a few of these different algorithms on the market, and you can see here the different ones that are around, and they're all slightly different. So virtually most of the ventilators, I think all the ventilators except for maybe one or 2 have this now. I think there may be 2 that don't have this as an option. But importantly, they're actually not all the same algorithm. They're all a little bit different in the way they work. And there's generally 3 types. I think for most of us, we probably don't worry as much about this. So the older ones were the fuzzy logic ones, which I always find amusing because that's apparently what my washing machine does. My washing machine apparently has fuzzy logic. It's how it works out how much to wash and whether to keep going. So I always keep finding that amusing when I hear that. So, but basically, essentially, there's a series of rules built into the ventilator. So it's told how to think. So it said, if this happens, always do this. If this happens, always do that. And they're predefined. So someone's told the ventilator what the universe does. And then we have the one that's in the Oxygenie here, which is a proportional integral differential algorithm, which is taking it to the next level. It doesn't just tell it what to do, it tells it how much to do it. So it says that if you have a really, really big change in your saturations, we need a quicker and more big change in FO2. And it looks at different components of it and will also put in factors on how quickly it will adapt as well. So it has a little bit more ability to be reactive or not reactive. So obviously if you are in 21 to 25% oxygen, you don't need the ventilator to be changing oxygen quite as dramatically as if you go from 40% to 80%, where as a clinician you'd want it to go very quickly. And I think this is, and then the adaptive model is one which attempts to try to model the oxygen dissociation curve. And I know that for the PID, Peter has always said that they feel that's a difficult way to do because you can't truly map that curve. You have to, because we're not measuring PaO2. So you have to make a lot of assumptions. So like all of these algorithms have had to make some assumptions because they can't see each baby. They're trying to make an adaptation that's generalizable. So it will mean in clinical practice when we've used it, and we were talking about this yesterday when we were having drinks in the evening, that there are some babies where, there's some circumstances where I've been at the bedside and watching it and I've gone, I need to turn it off because I want to react quicker. Yeah, because it's going slowly because of, yeah. And then sometimes it goes very quickly and that depends a little bit on what position you're in and how quickly, which FO2 you're starting from. And that's okay. But you've got to also remember that if you weren't there watching it and you had it turned off, it wouldn't react at all. So before you kind of sit there and go, it's not reacting as quickly as I would want, just turn it the other way and go, well, if I wasn't there and I didn't have this on, no change would happen. So, yeah. So sometimes a little bit is better than nothing here. Do they work? Well, the answer is yes, they do. If your outcome is to reduce the frequency of hypoxia or hyperoxia. And here is again some trial data with the Oxygenie, which is showing the percentage of time in a small group of babies that they were eupoxic when they didn't have it on and when they had it on. And you can see that for all babies, there was an improvement in the percentage of time, except for 2 where there was no change. So they spend more time in range. They generally spend less time in hypoxia and some of them less time in hyperoxia, but not all of them. Some of them have a tendency to overshoot a little bit. And they generally show a reduction in frequency of severe desaturations. And if you go and look, this is from one of the trials, and I did have this talk and I had lots of them. There's now multiple different papers which have reported this. So virtually every manufacturer's device has been put through the same crossover trial as this, and they generally all show the same picture. So I think as a general rule, the automated oxygen control units are working if your outcome measure is percentage of time in target saturations. So what do we know then? Well, we know that they're probably accurate. So as I just said, we've got a lot of these trials, and if you look at all of the trials pulled together, then they increase your time in the desired saturation range by about 13%. They reduce your periods of hypoxia by almost 10%. slight reduction in the number of hypoxic episodes, but when you actually period of hypoxia, but when you look at it, severe hypoxia, it's much higher. So they're able to do what they say they will do, and I think we can trust it there. I think often in these studies, when I've read them, I spend a bit of time thinking about some of these secondary outcomes, because I think that's probably where maybe we should be focusing. They all significantly reduce the number of times a staff member has had to change the ventilator's FiO2. So from one time per hour or less to 29 times per hour when it's not on. So if you're a nursing staff member working in the unit, then that's a considerable change to your focus of workload. And I think that's where we have to think about where there might be a role with these. This is probably one of the largest studies, which is one of the original ones, which was using the Clio, which is the one in the AVIA. So I don't even think if it's available anymore, the Clio. And this study definitely showed in this large crossover group of babies that it reduced hypoxia and hyperoxia. And I'm just showing you that just to show that most of the trials are still quite small in number, this is one of the larger ones. We've recently seen this small randomised controlled trial, which was published not long ago, and I think this was out of Oxford. They randomised babies, a small number of babies, who were in non-invasive ventilation for the first few days of life, to automated FO2 or manual FO2 for the remainder of their time on respiratory support in the NICU. So you can see that it was 200 days. So some of these babies were in ICU for a long time. And again, so this is a trial which wasn't just looking at short periods of time, but long periods of time on this mode of oxygen control, and was able to replicate the reduction in severe hypoxia and percentage of time in target saturations being better. So it suggests that if that's your outcome measure, reducing frequencies of hypoxia and increasing frequencies of eupoxia, that this seems to work over time rather than just as a short period of time, which is what all the previous studies shown. And again, this is data that Peter published a few years ago, where they summarised all the different manufacturers' published data for percentage of time in a targeted saturation range, and showed that you can see that they were all able to do it. Some of them were higher percentages than others, but generally between about 5 and 25% across the board. And I think the mean here was 19% of the time improvement. But there were some slight differences. But we should be critical, because all of these trials are talking about the percentage of time your saturations are normal. And is that a meaningful outcome measure? So it's a meaningful outcome measure if you're a saturation monitor. But is a meaningful outcome measure for a baby? And the answer is we probably don't know, right? So do we have any clinical trials that have compared automated oxygen control for other important neonatal outcomes? And the answer is we don't. So we do have a historical observational study which reported use in a lot of babies, which showed no difference in mortality or other adverse events. There is a large trial that's been recruiting in Germany and Europe for many, many years, and it was due to finish this year. I assumed it had stopped in COVID because it was already about 4 years in when COVID started, but I checked with the lead and they said they're still aiming to finish it. And that is using death and BPD as an outcome measure, so randomising to automated control versus not for the duration. We use death and BPD as an outcome measure in all our neonatal trials, but I would put it to you here, is it the right outcome measure here? I don't know. It's an important one. If we see a difference, that's great. But if we don't see a change in death or BPD, would we still say we wouldn't particularly think about using closed-loop oxygen? And I would argue the answer is no. What we want to know is it's safe. If it improves death or BPD, that's fantastic. If it has no difference, that's potentially also fantastic, because it means it's not dangerous to use. All of the clinical data so far is short-term, percentage of time hypoxic. So if we see a difference with these in long-term measures like BPD, then it's got to be because we're altering the percentage time of hypoxia and hyperoxia. But if we don't see a difference, then there might be something else. And maybe the right clinical outcome is actually staff workload. And I keep asking the people that make these devices, the clinicians, why do we not report in these trials adverse event rates? Because if the nursing staff are not having to change the Fio2 every 5 minutes, then presumably they're able to check a drug better. And they're able to make sure the TPN is properly prescribed, and they're able to do other things without being distracted. You know what it's like to be distracted. So I just wonder why we're not reporting. This is my beef. Why are we not reporting in these studies hospital-wide, unit-wide adverse event rates? Because it may be that we see no difference in the baby's BPD or death, but if we see a reduction in drug reporting errors and you've powered your study appropriately, then maybe you would go, actually, that a hospital administrator would say that's a great outcome measure, right? So maybe we need to be a bit clever here and think about different outcome measures. But this is me best thinking because I get paid to think at times. So interestingly, this study, which is now quite old, I think is an interesting one because all of the studies have looked at percentage time in normal saturation range. And this study, which I think is also from Southern England, did do that as well and showed what everyone else shows, which is that the amount of time you're in your target saturation range goes up with automated control. But they also had NIRS on to measure cerebral and end organ oxygenation and found there was no difference in end organ oxygenation, even though they were more time in saturation range, which again shows that the way we measure oxygen is really complicated. And maybe we need to think about doing more studies that look at cerebral outcomes as well to see if there's a change. Does the algorithm matter? So is one different than another? Again, we only have this one study. Apparently there's another one that's come out that I may have missed, which is a small study in the Netherlands, which was comparing the Oxygenie one versus the Clio, which is the old one, the rules-based one, and they did 24 hours in each. And they were able to show that the Oxygenie algorithm had more time in saturation range compared to the older Clio one, significantly more time. And interestingly, there were some differences in where each algorithm targeted. The Clio one was more likely to make you hyperoxic, and the Oxygenie one was more likely to make you a bit hypoxic. So they're each designed to be slightly different. And I think the message there is that probably the PID algorithms, and we suspect probably the other adaptive ones rather than the rules-based, the older ones, are probably going to be more reactive and responsive. But we have very little data on this. And the other thing which I think is a big problem is they're all currently linked to a ventilator. So you have to be on a ventilator. And I have to say, in our unit, the biggest reason we've struggled with this is that where we want to use it the most is in our babies on high flow and other things, particularly bronchiolitis. The preterm babies are in special care with 4 nurses looking after the whole special care or whatever. And we're not allowed to have a ventilator in there because it's special care. And you're not in Australia, you can't have a ventilator in special care. It becomes, even if it's only being used for high flow, that makes it an ICU bed. So we're not allowed to do that. So we now have, again, from Oxygenie, and I think SLE, you're now producing it, right? Yeah. We actually have the only one that's built as a standalone blender closed-loop oxygen control, which I think is really interesting because it potentially allows it to be used in less resource dense settings and to be used in special care. And I know it's been currently trialled, I think, in Gambia. It's been used in, there's a trial, Peters, there's a study going on in West Africa using it. It's not commercially available, but I think it's in the process of coming out soon. And again, using the Oxygenie, they were able to show that using this automated blender, they were able to spend more time in oxygen saturation. So I think this is potentially going to be a game changer for us because it's where we can start putting it on babies on high flow and in less resource sensitive areas. So all of these studies have been done in babies with acute RDS or recovering RDS, preterm babies. And so do we know if there's any benefit in using it in other populations? And in particular, the role in the term baby. The cardiac babies are really interesting because the algorithms will need to be changed to focus cardiac babies, but there'd be probably the risk of recurrent hypoxic episodes and hyperoxic episodes in the cardiac babies is equally as bad as in the preterm babies. And then in infectious diseases, particularly RSV, bronchiolitis and so forth, where we have a huge burden of disease in every setting around the world, right? RSV bronchiolitis is more of a burden of disease in infancy than prematurity is. And many of those babies need to be managed in less resource settings because we don't have enough critical care capacity. So we've just got under review at the moment a small study, which is similar to all the others. It's a crossover study of, and this time again with the Oxygenie, where babies who are term with acute hypoxic respiratory failure, so CDH, MAS, and pulmonary hypertension and NARDS, and also babies who are in with proven lower respiratory tract viral infections like RSV. And we did exactly the same study where we randomised them to having periods of time with it on and with it off, and they were meant to have 2 periods of time with it on and off over 2 24-hour periods. We aimed to recruit 50 to 80 babies, and of course COVID came, and we recruited 14 babies. So, of which, and 20 periods of exercise. But we've just put this in. And again, we showed exactly the same as you'd expect with preterm babies, that with the oxygen control on, you had more time in normoxia. So that again shows that it's probably likely that the algorithms will work in across all of our neonatal age ranges and conditions. Are there risks? And I think we have to ask that because we just talk about percentage and saturation. So are there risks? We don't know if there's long-term risks because we don't have the trials. But probably there's no great risk at the moment. You'd expect on face value that it's going to show no difference or a benefit compared to having it not on. You can't see a rationale for it being dangerous per se in terms of ROP unless the algorithms don't work. But I think, and this is a really big part of this, there are risks that are not direct to the patient because it requires you and your staff to rethink how you monitor a patient. Because automated oxygen control is treating SpO2. It's not treating the cause of the change in SpO2. So it's not able to say, you've got an infection and you need to treat that. So we need to be aware of that. The other thing is, how do we know a baby is getting sick in the NICU? No? Pardon? What happens? Yeah, but what happens in the NICU that makes everyone run? It alarms, right? And what are our alarms set to? Low oxygen, low saturation, high saturation, low heart rate, high heart rate, right? We have and apnea. We don't tend to run, that doesn't alarm that often for blood pressure, right? What we're doing here is turning on something which is designed to reduce the chance of your saturation alarm desaturating, right? Now, it may be that your saturation stay in range, but your FO2 is gone from 21% to 100%, right? Over 20 minutes. And your saturation stayed normal because you've got this amazing machine which can manage that. But we need to know that patient's got sick, right? We would all say that's a sick patient. Yep. So you need to start thinking about what instability is. So instability won't be desaturation. It'll be oxygen change or something else like heart rate, frequency of of bradycardias. So I think for me, that's the biggest thing. I actually quite like using this. We play around and use it quite a bit now, but I'm cautious about saying, hey, we've got this great thing, just turn it on, without training your staff. Because we've definitely seen situations where in our lab work, where we use it all the time now, we've been getting excited playing around with ultrasound and all this other stuff. We've got 2 neonatologists, minimum, next to the patient 24/7 in the lab. And we're getting excited about something. And then one of our scientists who has no training goes, oh, by the way, did you all realise the oxygenation went up to 100% 10 minutes ago? And no alarm went off, right? So I can imagine that if you're in a busy NICU and you haven't trained your nursing staff, that's a risk. So if you're going to introduce it, you need to think about how you train your staff and what you look at. And you need to sort of, and I was saying, I'd quite like it to alarm if the oxygen changed a lot, but you guys, apparently it's been turned off because of people complaining it was alarming too much.
You still have an alarm on
Yeah.
the FO2.
Yeah.
So if you can set an alarm on your FO2. So it means if your FO2 increase above a certain level, it will give you an alarm.
So I think you really have to make your staff well aware of that, and you need to start looking at other things like your frequency of bradycardia. And it may be that heart rate is actually going to have to be what is our desaturation thing, you know. So in summary, I think we have clinical experience and engineering experience that it can be used in all modes of respiratory support because it's a functional product and not a mode. It's actually pretty easy to set up, and we can show you here if you want to see how to do it. I think it is pretty accurate for what it's designed to do. Theoretically, it reduces staff workload. It may not reduce staff anxiety because, again, that's around training. Our experienced nurses, when we've used it, some of them have said, this is fantastic, and some have said, I don't feel comfortable letting the machine do this, right? And then probably our middle ground has been with our senior nurses. They actually say, this is really good. When I'm doing something else or when another nurse is on a break and I'm managing 2 patients, I'm going to turn it on. When I'm focusing on the baby's respiratory care, I'm going to turn it off because I want to be able to do things. But that's my job then, is to focus on that. So I think that's a very mature response from a senior nursing staff to sort of say, well, I realise here I'm ignoring my patient, so I'm going to let the machine do it. And then when I'm focusing on the lungs, I'll focus back on it myself. So we don't yet know about long-term benefits, and I think we probably could understand exactly which groups it might be best in and how to do it. So anyway, that's a summary for those of you who are not familiar with it. And I don't know if you wanted to ask any questions on it, and then we can show you and play around with a few other things. But more importantly, there's no more slides to show you.
How many patients do you have?
Yeah, so our unit is a 36-bed unit in theory. We rarely have 36 babies since COVID because we never have enough nurses, and I don't know if that's like it here in India, but since COVID it's been really hard to get nurses. So the amount of times I have to close our unit at 28 patients when I'm on, and I can see like all these empty beds because we can't nurse them, because in Australia we have quite strict ratio laws, as many of you know. So if a baby is on a ventilator, they have to be nursed 1-to-1. So our oscillated baby is 1-to-1. Convention was meant to be 1-to-1. And ECMOs, I think, is 2. Our jet babies and ECMO babies are 2 nurses to 1. If they're on non-invasive ventilation, they're meant to be 1-to-1 if they're on CPAP, but generally they're 1-to-2 is what really happens. And in special care, it's 1-to-4 or 1-to-2, depending if we're on high flow or not. So we've got high nurse ratios. Yeah. And I would expect that in many places that's not happening, right?
So I have a question. How does it differentiate between the true low levels of SpO2 and falsely low saturation? Is there any algorithm?
So it can't initially, but when the probe comes off and it drops right down, it starts alarming a lot. And you can deactivate it, but that is another problem. So if your probe is off, then it will start turning the oxygen up.
Normally the signal should stop.
The signal stops, and then after a while, it does. After a while, it turns off.
No.
Doesn't it?
No, it will. If it doesn't, it continuously monitors the signal
Yeah.
quality. If the signal quality
drops,
it
alarms.
Then you will have the alarms, and the ventilator keeps the last FO2 that was set.
But it can go up quite high quickly, but it alarms,
It shouldn't change.
Depends if it suddenly comes off or if you slowly lose signal.
No.
Yeah. We've definitely had ones where we've had a poor trace and it will increase the FO2, and then you readjust the probe and you get a better trace and it will come down again. Not comes off, but you just lose the quality of the trace.
Normally the quality, when the quality is
really
below
poor,
certain
level, but in that sort of in-between range.
Okay.
Yeah.
Because normally
But yeah.
it doesn't increase,
It doesn't change if it's,
it doesn't move.
Okay. Any other questions?
Yeah, and just the proportion of rise in FiO2, is it proportional to the degree of drop?
It depends on the algorithm.
Depends on the algorithm, right? Because if it's from 95 gone to 60 versus 85,
Yeah.
yeah. So the Oxygenie one,
My experience,
Yeah.
you probably know the engineering better than me.
There's a background of how. So it takes in part, partly is how
That's what-
and also where you are on the dissociation rate.
And that's why I was saying that sometimes I find I have to turn it off because if the baby,
yeah. So you
if
have
the
to override.
patient's, if the reference range is very low, and then the patient goes up to a high FO2, it can sometimes
Slow to go down.
be slow to go down, and I'll turn it off to wean quicker. It'll
Or-
react
or the other
quickly in
way
going
around.
up.
Or
Yeah.
the other way around, if baby is taking longer time, then you want to try.
It tends to turn up very quickly
Okay.
if you're at a low FO2 as your reference and you suddenly desaturate. But yeah, it can sometimes be slow to
to
wean
come down.
if you've gone from a high from a low to a high because it's saying you're a long way from the reference, so it's being more cautious. But that's the advantage of the adaptive and PIDs. They're meant to be more reactive to the different variabilities in the system than the old-fashioned ways. So,
Only clinically stable babies or because hemodynamically unstable babies will not be benefited with this oxygen.
You will take over.
I think actually in the really unstable babies, it's probably a really good thing. So I think if you're resuscitating someone, no. But when you've got those, the BPD babies, those little preterm babies which are sitting there having lots of A's and B's, but actually they don't need much ventilation change. It's just they're always fluctuating. And I think we don't have data, but the group I would really like to see it on is the babies with pulmonary hypertension, because the changes in fluctuations often are the problem. It's when they become hypoxic, they become quite unstable. So I think in those babies, it actually makes more sense to soften their curve out. Like,
Perfusion is not good. We have to achieve first good perfusion, good hemodynamic stability.
yeah. So here you can see in this one, if you've got if you've got a baby that's having lots of A's and B's, actually blunting the number of A's and B's out is a good thing. And you probably need the Oxygenie there, because what happens clinically is when you have a baby of lots of A's and B's, you tend to just end up targeting a very high saturation range. They're more likely to be in 100% oxygen. So I think having that reactivity is useful. So,
Yeah, I mean,
Might be good also.
it has to be accurate. So you have to have adequate perfusion index. Otherwise, it will stick. But I think in Indian setting, it is still more useful because a lot of time the nurses are not allowed to tweak the oxygen a lot. It's the doctors who decide, okay, keep on 30%, keep on 40%, and it's not done like every hour. So there, I think it is very useful.
Even our staff ratio is
Not as good as, yeah.
but I just come back to highlight the point which I think is important. If you are going to use it, you need to think about how you train with it. And you should practice using it first yourself rather than just saying, oh, there's this great new toy we can use. Let's turn it on. This will be great for you all because you won't have to turn the FO2 off. But someone has to adapt to it. So like everything, you need to make sure that you thought about it and trained properly, because it does change your outcome measures for instability. We've got some time left, and normally what we do is just demonstrate things on the ventilator. We actually have a much smaller group now. We could almost just come around the ventilator, or if you're feeling really tired and need to sit, but if you could bring a chair too. What? Well, then we don't need the camera so much.
Pure long is with a shunt and things like that. So, and it looks at 1 hour of data. So when you start, of course, you don't have 1 hour of data. So the ventilator will use the FO2 that you set as a starting point, actually, to assess how sick your lung is. So it means that if you start at 21%, but actually the requirement of your patient, the base is around 30 outside of the episode of hypoxemia or hyperoxia, ventilator will be running after your patient. It won't work properly. So it's very important when you start to maybe take a little bit of time to observe your patient, to have an idea of what the base is before starting the ventilator, because ventilator won't react at the maximum that he should. So you're sick. Huh? So you just, once you have done that, you just do a long press, and then you have Oxygenie available, and you just.
And it shows the target range you've set. So hopefully it should turn the oxygen down now, right? Because I'm saturating at 100%.
So we already started at 32. Yeah. So depend on your oxygen. Is doing a lot of fluctuation. Maybe you want to make it longer. If you're not comfortable with that, I just give this one. So here is to remove the delay of the audible alarms. So it means that here, for example, you set a low target at 90. Your low alarm of the SpO2 is at 90. If it drops 5 below at 85, immediately you will have the alarms. It doesn't give you any delay. So like that, you know what is happening in your patient, and you avoid some alarms. I let you.
Right, so hopefully we can go.
Ah.
So
Yeah.
we put my. Do you want to turn it on?
No, I want to change.
No, I was going to say if it starts high, I'll hopefully be saturating high, right? And it'll
It
come
will be
down.
very slow
Okay, all right.
because your reference auto is very slow.
Don't go all the way down,
No, I
because
will.
I'll be hyperoxic here. Hopefully.
You
I
will be.
set the target range to 90 to 94.
So before starting Oxygenie, one of the very important points I mentioned to you that the ventilator will take into account how sick your lung is with a shunt and things like that. So, and it looks at 1 hour of data. So when you start, of course, you don't have 1 hour of data. So the ventilator will use the Fio2 that you set as a starting point, actually, to assess how sick your lung is. So it means that if you start at 21%, but actually the requirement of your patient, the base is around 30 outside of the episode of hypoxemia or hyperoxia, ventilator will be running after your patient. It won't work. So it's very important when you start to maybe take a little bit of time to observe your patient, to have an idea of what the base is before starting the ventilator, because ventilator won't react at the maximum that he should.
Should I go on?
So you're sick, huh? So you just, once you have done that, you just do a long press, and then you have Oxygenie available, and you just.
And it shows the target range you've set. So hopefully it should turn the oxygen down now, right? Because I'm saturating at 100%.
So we already started at 32. Yeah. So depend on your oxygen. Is where, yeah, is where, is keeping going up and down. Is where you might want to take over to. No, it's okay.
So, see if I can make my thumb, my finger hypoxic.
Is how I want to show that if the signal quality goes down, ventilator will stress.
Yeah. Yeah.
I have never managed.
There is no signal. It will not. Yeah.
So now I'm in right now. But now I'm in air, it's just going to stay.
So depending where you are, when you start, here you are at 30. But if you work, so if you use Oxygenie, the reference O2 is a value that the ventilator has calculated, is a requirement of the FO2 to keep your patient within the target outside of the episode of hyper or hypoxemia. So it's telling you the base. The ventilator, we don't have it in the trains, but I will ask the team actually to note this one, because this one is telling you actually if the requirement is increasing or not. Because when you have the nurses, they might go for hypoxemia, we go up, and then we see if they go down to the same points than we started. And if after a few adjustments they see that they keep going up, actually they might call you and say, oh, yeah, I might have a problem. But here you won't see it. But what you will see is your reference O2, which is recalculated every 30 minutes. will go up. And with tips you that something change. And on the graph is this line, the dotted line here. So this one will be, the first time is 1 hour, and then every 30 minutes it will be readjusted.
We delay Venus return. Okay, there's probably not much more you can show with this.
Yeah.
Are there any questions?
So you'd actually start using the Oxygenie pathway once your ventilation is stabilized, because otherwise your pressure requirements would be, because otherwise the FR2 would inordinately rise when what actually was needed was a change in the pressure.
But
It should be there, and then
if you're going to, you could run it during this, so there's no reason why we couldn't do an open run, for example. But here again, you can't use saturations to measure. You have to use an improvement in FO2. So you could do an open lung with this and increase your mean airway pressure. And if your FO2 is decreasing, and you say
So you have to be by
so you have to understand that's what you're measuring. Yeah.
so that runs.
Yeah.
So all the things can be seen as your ventilator things, brackets can't be seen as the same.
And I just show you one thing. Here is where you have the FR2 arm. So you can increase by 40. Here you can go up to 70. But if your patient is rotating, 26, 27, what you can do is here you have your arms and you can set it at 30 for example, in the lower section. And if the patient is the effort to go to 4, you will have an alert. It doesn't prevent it from going higher, but after the progress. That is what is important. It's also to set your ventilator, you have maybe new alarms to set.
And you can tell me what else to do. You can go back to this way. And this is a traditional. Hello. No, yeah, so then you can add so you can add an oxygen which I think is quite useful. But you can't see the FO2 change here. So when it's on, it defaults to this one, which only gives you one of the ventilator waves. So if you want to see that, so yeah, you can't get it all in one screen. So it depends on how stable your baby is. If your baby's very stable, you can have pressure or volume here quite easily. And then see all the oxygen ones. But if you're needing to see all the volume data, then you probably need to have just the saturation growth out. But you won't see your oxygen. Right.
And it can be done in all the invasive or all the non-invasive.
We've definitely used it a lot.
I think that's maybe the weaning might be, your high
Weaning,
flow
yeah.
nasal cannula.
Yeah, I think weaning is probably where it's got a benefit as well. Especially. Right, yeah.
The lowest one is
I clicked that one, so that's
So we have a cyanotic.
No, you cannot do that.
no, it's not, it cannot be used for cyanotic.
Yeah.
Yeah, so, and that's important. It's no stable.
But it could have been upgraded, like, next software. Because then you can have like 60 to 80 as a range.
The association curve is different.
It's very different, so you
Yeah.
have to rewrite it.
Yeah.
To write a new piece.
New piece of
Right. Do you want to keep doing more things? Or are you so tired you have to go?
What should be the ideal lung between segment? It is 10 seconds for all the
So this one, it will be defaulted to 2 to 4 seconds because the minimum time between two adjustments is 1 second. So you need a very fast feedback. And it is something that you have to be cautious if you start Oxygenie and you have 2 SpO2 drops because you will read some very different data on the ventilator and on your monitor. Your monitor is most of the time is between 8 take a smaller frames, you will see more fluctuation going higher and going lower. It can be disturbing when you have scopes or something. But you have to trust it. Maybe you hide the one on the scope. It's the same technology, it's a massive.
So if you were neonatal consultants, trainees, fellows, so like trainees, consultants.
Junior to the seniors.
You're the most senior. I was just saying that there's a hierarchy. Junior to senior, you're at the end of the line.
I didn't know she was behind me.
So, do you want to? No, I've turned the sats off, so it shouldn't. Yeah.
Yeah, it's with
So, if you have a preterm baby who's got HMD, 28 weeker, not ventilator settings, you can put them on prevention. There's no right or answer, don't worry. And you've got that. Yeah. No, it's a couple of hours on, so, and you intubate. You just intubate. Six. So 20 on 6? No, you just intubated. What are you going to do? Yeah. What time? So the baby's 1 kilo. That's nice. Yeah. That's it. Good. Yeah. And what about the other numbers? Don't worry about that. Just leave it.
this one is
We're on a. Don't change that.
sorry,
We're on a compressor, so don't change it. Yeah. These other ones. Yeah. What else? What mode would you use? What mode would you use? Pressure trigger? Why? Why would you use pressure trigger?
Patient trigger.
Patient
trigger.
PTC.
No, patient trigger.
Yeah. So what are you wanting to do there? You're wanting to trigger. So you can. So you want to synchronize every breath, don't you? The patient has. Is that different from SIV? Why? What's different? Trying to tell us the hard way. Don't worry. Yeah. In both of them,
The SV is the one where the item
PSV, yeah. So, yeah, we're not going to use that one yet. No, I was asking the difference between
Please
cream
set the rate. Suppose I've set it at 30. So there will be 30
Yeah.
rates which will.
So here, yeah, you're exactly right. It will trigger how many breaths?
So it's this is a sample, right?
Yeah.
So I've kept the rate
So he's,
So baby is breathing at 60.
so I'm sorry, how fast is this baby breathing?
You have to wait because it's over-calculated.
But you can see on the wave there. So some of these breaths are unsupported, aren't they? How do you know what a breath is on, a triggered breath is on an ventilator? Yeah, and what else? Yeah, they change colour. They make it easy for us, right? So you can see here we've got a lot of triggered breaths and not many pressure change, right? So you're exactly right. We're only supporting 40 breaths. We're offering many more than that. And PTV allows us to do what? It's all the breaths, yeah. So hopefully we'll see that now. So you can see now that we're triggering the breaths. And as you say, the micro. So this is good, is it? We're happy with all of this?
Here, if the baby is breathing, the baby takes more to breathe. If he is in fact breathing, then ESP will be better.
Oh, yeah, they both win. I was going to say, right, I'm just going to stop so I don't have to keep doing this all the time. No. So, how do we know, how do you define what a breath is on a ventilator? How does a ventilator know the baby's breathing? Yeah, so how does it triggers off this, right? Yeah. So what's the flow trigger here set at? 0.6. So if you have a look at this flow wave, this baby has to generate all of this gas flow before it triggers. So do you think that's the best trigger for this one? What would you do? The peak flow is 2 litres and the trigger is 0.6. So that means this baby, 30% of the baby's inspiratory effort it has to do without any support. And then the rest of the initial inspiratory effort gets support. So here we may say, right, we actually want to turn the trigger down. So it goes down to 0.2. So you can see here it's much lower. Now the risk here is you can auto trigger a lot more. So chaos in the system. But I only have to take a little breath here as triggering, right? If I set this up very high, we'll just go to 0.8, 1. There's less, I don't have to actually, I can take a little breath. So always make sure you just check that the trigger is low enough to support ventilation. Are we happy with the rest of this ventilation settings? Are they perfect? What do you think? Yeah. Ask it back too. What's wrong? You could also say, I think it's time to consult. We've got the item too short. Yeah, well done. So is that why you changed that? Does everyone understand that? Yeah. It's okay to say no, because most people don't. Yeah. Do you see here? That here, we'll pause it. The flow is going into the lungs. Okay, and then inspiration is this bit here, expiration is this bit here. You can see that expiration is actually starting right up here, before the lung has got back to zero flow. So when we take a breath in, we have gas moving into our lungs. At the end of a full breath in, there's no gas moving up, so flow should be 0, and then the direction of flow changes the other way, and it should get back to 0 again before the next inflation. So here, exactly right. I've never seen anyone do this first time. So excellent. So you don't need to be here at all. The eye time here is too short, right? So we're on targeted tidal volume, and in this mode, we're denying the baby some tidal volume. So it may not be a big change here, but you had a 0.35, didn't you? And what did you want it to show? Where is that?
You won't be able, because you have a regulation where the PIP can't go below 3.
Yeah, yeah.
That pressure.
Oh, yeah. Okay, I'll fix that in a minute. How do you want this wave to look? Is that? Did you say 0.35 or did you have it higher than that? Yeah. Still not doing it.
You have
That's still too short, right? So this lung is not like a newborn baby lung, is it? It's a bit different. But this is the lung we've got. It's not the lung we think we've got. It's the real lung. That's getting closer, right? Obviously, and if we look at our tidal, our pressures are so low. If we go much higher than this, we'll go really high. We won't get inspiratory hold yet, but we risk it. You can see that we've got a period of zero flow. So you generally don't need to have much zero flow. If you're apneic, just a little bit of zero flow is good, so you get gas distribution. But here, probably it's about 0.6 that you want, right? That's probably perfect, yeah? And what about our expiratory time? Is that adequate? Do we have zero flow? Yeah. So if you've got a blood gas here, which was, the CO2 was really high, what would you do to bring the CO2 down? You're hiding in the back, I'm going to ask you questions. No, it's all right. I'm just joking. What would you do here?
Respiratory rate or delta P.
Yeah, which one are you going to do?
But here we have kept the TI of 0.6.
Yeah, the TI is perfect.
So each
Yeah,
if you increase your TI, no additional time.
yeah. There won't be any additional tidal volume going in here. You could increase your TI a little bit. You might get a little bit, but eventually you'll get no further tidal ventilation. So you've only two things to change. If your I time is correct, you can change. There's three things you can change. You can change your P, you can change your rate, or you can change your tidal volume. Let's assume we've got the right peak. Obviously, if this peak was 3, then I would be. But let's assume it's the right peak. So you're going to change rate or tidal volume. Which one would you change? Here to bring the CO2 down.
you can either change the rate or the tidal volume, set tidal volume.
Baby's breathing already high.
CO2 is high.
Well, to a pole, which one would you
It
change?
is a patient-triggered ventilation, so we'll try to change the target volume.
Okay, but at the moment our patient's apneic. So let's assume we've muscle relaxed this patient. I'm just trying to go for a forward exercise for you. Yeah.
Then we'll reduce the rate.
Right.
Because we have
Increase the
control.
rate.
Increase the
You would increase the rate. Would you increase the rate or change tidal volume?
increase the patient.
Breathing.
One is on the
Then we-
Sorry?
tidal volume first, and then
Kieran?
inspiratory time also.
Depend on the lung disease, but I think
Right.
rate is achieving.
The lung disease. This
So
is
it depends
actually
on
the
what
lung
state
disease. It's
of
telling
ventilation
us.
you're in.
Yeah.
You know, if
So he's not using a lot of high
probably
pressures.
I would increase the rate
that
because
is-
it would be less volutrauma.
Yep.
If
Exactly.
if you're in the early
Yeah.
stages and if there is scope, suppose it's
45.
slightly bigger baby, then you may consider. But you
Rate or tidal volume on this patient right now.
This patient.
Not every patient, this patient.
He's got PIP.
Because we're not treating any other patient.
He's got a very
Rate if the oxygenation
CO2 is very high.
yeah, and if the oxygen is not too high, if you don't want to change the oxygen.
So would you do rate or tidal volume? Yeah. Why is that?
this is assuming that the oxygenation is okay.
Yeah.
My tidal volume.
Why would you do rate?
Because you're only focusing on the CO2
Yeah.
at the moment, not the
But
oxygen.
why would
There's
because
still
both
time
will
may
work,
not, the
right?
E-time is
Exactly,
still
yeah.
giving
Both
some
will
scope.
work exactly the same, and I agree. I think I agree with what all of you're saying, right? Because we're worried about giving more pressure and volume, right? We hate that because we're neonatologists, right? And as you have clearly said here,
complaint lung.
you've got this whole bit of zero flow. So the lung is finished expiring, and it's waiting before the next breath. So we can safely put more inflations in here without causing over auto peak. Oh. So we go in here, and now you're seeing we're getting back to zero flow, and we've got more breaths in a minute. Our minute ventilation will have gone up, and we haven't changed our tidal volume. But right now, if we went up again, this is about as far as we can go, right? But I'm just getting a little bit of auto peak. If we keep going up, I just want to keep doing this just to show it. Now, our PIP's going up, right? Because we've got, see how the flow is not getting back to zero? This is auto peak that you read in the textbooks, right? So, when we had the first wave, we had all that time at zero flow. So we can increase rate without having to increase tidal volume and get CO2 clearance. But here, if we increase rate, we're going to cause auto peak. So if we had the same blood gas now with a high CO2, we have to increase tidal volume, don't we? Because increasing rate will be bad for the patient. So you can use the waves to help you understand what the right thing is, right? So why do you think our eye time's so long? Because this is not what we see on normal babies. Babies don't need these long eye times, do they? This is a pretty normal eye time in PICU though.
This is designed as a old patient lung probably.
This lung doesn't have any disease.
Yeah.
Right?
It's a
So a
compliant
healthy
lung, but-
lung
yeah.
is the time constant of the lung is the time you need to be able to get gas in and get gas out of the lung. Well, actually, the eye time is 5 time constants.
Yeah.
So, and it's telling us about resistance and compliance. So at the moment we have a lung that has fairly normal resistance and compliance, right? If we increase the resistance a little bit, that one's better, the middle one. That's a lot of resistance, right? Now we've got a very asthmatic-y sort of beat bronchiolitis on. But you can see our wave has dampened because, it takes a long time for gas to move. So our peak flow will be less. We've got the same volume in, but it needs more time for that volume to move. And you can see now our eye time is way too short, and we're getting auto peak. So we'll have to use a much lower rate. We'll have to go do what they do in PICU and put babies on low rates. And we'll now need a much longer eye time too. And now we're starting to see a better picture. And we can probably have a rate of about 40 to 45 there as the right one. So now we have a problem. That's too much resistance, right? Now we fix the resistance, we've unblocked our tube, and now you can see that our numbers are all wrong and we have to change them again. But we don't, what about this? What have I done here? Sorry?
Reduce the compliance.
Yeah, I've made, this is a stiff lung. So, yeah. And what's happened to our time constants?
Hold has increased like crazy.
Reduce
Time constant decreases, doesn't it? Resistance is normal, you can see that here, and the compliance is down, so decreased compliance, it's compliance times resistance, times 5 is your eye time, so it's now gone down. So that's why preterm babies need much lower eye times than term babies with normal lungs. The baby who comes back for their malrotation repair is going to need a very different set of ventilator settings compared to the baby who's a preterm baby that you have. So now, do you want to, you've done all of this, does someone else want to set the eye time here? So the consultants never do it, do they?
Reduce it.
Yeah.
Go down.
Why don't you find it for me?
0.4.
Which one's the right? You tell us which is the right. You're doing all the hard work.
You need to increase
Still
it again.
somehow 0.45.
I'll make it even more non-compliant. There you go, Norman.
Yes, sir.
That's too long now, isn't it? That looks pretty good. Well done. And you can see that we can have a lot more breasts now, right? And for a preterm baby, they often spontaneously breathe at 60 to 80, don't they? And we can see why they can do it. And you can also see why we would use, in a preterm baby, a fast rate, low tidal volume, is mechanically appropriate for the baby's lungs. But a baby with bronchiolitis, a fast rate may actually be 20 or 30 breaths a minute, not 60. So you're using the fastest rate you can for the baby's lungs with the lowest tidal volume you can. So why did you pick 4? These people did it. Why did you pick 4 to 6 mil per kilo in volume guarantee? Oh, and you should now see that our PIP has gone up, right? PIP is 10. If I took it out, I think it was very small, wasn't it? Why is our PIP not coming down? I've taken the compliance problem away, and our PIP is the same, 9.8, 9.9. Why is that? Eye time's too short, right? Let's see if this drops up. It should do. So not dropping up. It should drop the PIP. Surprising. Try it up and let's try
Let me
it.
check something. PIP of 5 and the PIP is
10.
the same.
Try much higher. It should drop the PIP when we increase the eye time. Now you won't believe me. You should put the PIP up. If you have your eye time too short, in volume guarantee, generally the PIP will go up by a centimetre or 2 of water. So you should start putting the PIP up. It's done it a little bit. But I'll go back to this one. Why did you pick 4 to 6 mil per kilo? How do we know? How do we know? Why do we know 4 to 6 is normal? So we don't have any large population studies of preterm babies. But I think I was saying yesterday to people, we have some data from term babies that normally when they're breathing they're about 4.5 mil per kilo. And it comes down to the dead space. So we're ventilating here, right? That's where gas exchange occurs. But the ventilator is delivering tidal volume based on a measurement here. So we have to take into account the dead space. So we need to ensure we've got enough alveolar ventilation, which is generally about 2 to 2.5 mil per kilo. And the dead space is generally about 1.5 to 2 mil per kilo in a normal newly born baby. So 4 mil per kilo, 3.5 to 4 mil per kilo is generally the lowest tidal volume. So obviously we want to use the lowest possible tidal volume. So somewhere around the 4 to 6 range will be appropriately right for most babies shortly after birth. But if the dead space changes, then you'll need a higher or lower tidal volume, right? So when does our dead space change? Yep, so yeah, but that's actually quite a small component. So everyone gets really worried. I don't know, when I was a trainee, everyone was cutting the tube. As soon as you intubated, you get the chest x-ray, and then trim the tube straight away, and then inevitably you couldn't get the ET connector in, and someone's trying to dilate it, and the baby's going...
We used to keep it 4 centimeters beyond the mouth.
Yeah,
That's it.
and
That's
I
just
don't know,
switch
is it
off.
like that in India now?
We
But
used to do that.
and now, what do
For
people
20
do?
years. Now we keep
No one cares.
Yes.
Like you go on the order and all the tubes are just the normal tubes in. And I think, is that in Britain? Do they still cut the tubes? It's harder to change their practices, eh?
Yeah.
They've done it for 300 years. They're not changing now. It may make a difference, but most of the dead space is below, isn't it? It's the dead space here. Yeah. So I don't know. And then you get these
It
babies
probably
with
makes a
tubes.
difference to the resistance. It increases the airway resistance
Yeah.
to an extent.
It probably matters
But it
more in a
doesn't
2.5 tube than a 3 and a 3.5 tube. But most of your dead space is actually in the lung itself anyways. So when does your lung dead space, your your airway dead space change?
When you have shunts,
Shunts, yeah.
So,
intrapulmonary shunts.
Intrapulmonary.
yeah, that changes your relative dead space, yeah.
Chronic BPD, tracheomalacia is there.
Yeah, so in chronic BPD, when you're born preterm, over time your airways dilate. So if you're 33 or 34, if you're 33 or 34 weeks after preterm birth, you have bigger airways, and they become a bit more malatial as well, so they collapse, which is what we know here. So you'll need, if you ventilate, as I was saying yesterday, if you ventilate a 28-weeker, maybe on day 1, you're going to use 4 to 6 mil per kilo. But if that baby is being ventilated at 35 weeks corrected for its stoma closure, you will often need a higher tidal volume. And I'd probably start that baby at 5 to 7 rather than 4 to 6. Some people would start that baby at 8. And if you have a baby with really nasty cystic BPD, at term corrected, they often will need 8 or higher mil per kilo tidal volumes. So just be aware that in preterm babies, your dead space changes. So the 4 to 6 is, and remember, that's the lowest range. And if you're not clearing CO2, you need a higher tidal volume. But as a general rule, if your tidal volume is going up and up and up, then what should you ask yourself? So say you're on conventional ventilation of volume targeting, you keep doing blood gases, you're underventilated, so you keep increasing your tidal volume, and your tidal volume, you've got 4, 5, 6, sorry?
You have to see a PIP limit also, like what is the PIP max we have set.
Yeah. So, but you keep coming back and saying every time the CO, we're having to increase our volume guarantee more and more and more.
Leaks.
Yeah, it could be leak. What else? I'll come back to leak.
Check your flow also.
Could be for obstruction. Yeah. Anything else?
The lungs are
Could be not recruited. Yeah. So just remember, if you have poor CO2 clearance, it may be an under-recruited lung, because or an over-distended lung. Both of them cause an impairment of compliance, which means you need a higher tidal volume. So there's a very famous old, which was quite old now, Canadian anaesthetist who was one of the founders of high frequency, Alison Fruits. I don't know if you remember. She was doing a lot of studies she did all the animal studies on high frequency in the late 80s and early 90s. And she used to always say with high frequency, if CO2 is your problem, go to your mean airway pressure. Which is different from what we teach, right? She always said, and I think that's really important. So don't forget that in most cases you don't need to do that. It's just that you need to change your tidal volume. But if it's a persistent problem, ask yourself, have I got the wrong peak? And it may mean you need to change it. That's a sort of a more advanced trick. But 90% of the time you're going to change your rate, you're going to change, and if they're breathing, you don't change your rate, you're going to change your tidal volume, aren't you? Yeah. And you can look at your minute ventilation. So what's the normal minute ventilation of a neonate for CO2, appropriate CO2? You are mouthing an answer. Why is that? What's your reasoning for that?
Depending on the rate at which they breathe.
Yeah, so it's rate times time volume. But it's about right, yeah? So this is not alveolar minute ventilation, it's minute ventilation measured on the ventilator. Because alveolar minute ventilation will be a bit lower, won't it? Yeah. But if you think about it, around about, I say 240, 200 to 240, but 300. Think about a preterm baby, they're on a rate of 60, 4 mil per kilo. That's about 240, right? Yeah. So you can look here, and you can see here it's 400. So we expect that if we divide that by 1 kilo baby, that's actually a pretty good minute ventilation. I think our CO2 would be good. And we'd probably expect that anyway because of how good the ventilation was, how easy it was. And it's a good way to look at your blood gases too, to look at that number. So if your if you get a blood gas and you've got a CO2 that's really high, and your minute ventilation is like 120 mil per kilo per minute, then you know what's wrong, right? Where's the problem? The problem's me. I've got the wrong numbers. Yeah? I'm underventilating that patient, and almost certainly I've got the wrong tidal volume or the wrong rate, and I'm the problem there, or the wrong peak. If my minute ventilation is actually pretty good, and my CO2 is going up and my oxidation is getting worse, that's worsening disease, and you'll probably be targeting a higher thing. So yeah. So I do look at this. I don't know. Do you look at the minute ventilation a lot? I think people ignore it on the ventilators because they look at these. But I think it's a really useful one to look at to help understand your blood gases as well. Yeah. So what else could we show? Do you want to know? Because you know all the answers.
I want to know a little bit about the rise time. Is it, do we alter that anytime?
All right, I'm going to ask you all. Do you think we should alter the rise time?
We usually never touch that parameter
No one
at
ever
all.
touches the rise. What do you think?
Sometimes, especially in the chronic BPD, especially when they are non-invasively ventilated to improve oxygenation.
Why?
Again, I think it's a resistance thing
So-
just to help.
Helps to improve the map.
What does the rise time do?
Increases
What
the
is it
area.
Decides how gently
So here the rise time is very quick, right? So it's the amount of time that I'm going to put the rate up just so that we can see more breaths. Yeah. So and I'll just get a few in. It's the amount of time it takes to go from peak to peak inflation pressure. So the quicker the rise time, the more square the wave. The slower the rise time, the smoother or more curved the wave. And we'll just drop that right now. No, I want to show it first. We'll start at one end. So now we have a really very quick rise time, very quick wave. Yeah. And then we've just got this bit of pressure equilibrization. If we were on an adult ventilator, that's where they talk about the not the overshoot, that's where the driving pressure is, because it's where your plateau pressure is and all of that, but it doesn't matter on our ventilators. So now we've got a very quick rise. Look what happened to our flow. To generate a quick change in pressure, you have to push gas really quickly, right? Yeah. And now we'll go. So this is not quite that far, just yet. This is 2/3 of. So our I times 0.3, and now our rise time is 2/3 of the I inspired time, and you can see the very difference in the waveform and what's happened to our pressure, our flow wave. It's blunted, hasn't it? So why is this a good thing? Well,
Rheotrauma.
yeah. So rheotrauma, we don't have any clinical trials of this, but potentially rheotrauma in very sick, non-compliant lungs. When you've got resistive lungs, it's not so important, right? Because you've already got something slowing gas flow down. It potentially helps with distribution of gas within the lungs, which I think is what you were alluding to. Is that right?
Heterogeneous.
You get more heterogeneous gas flow. Now, we're just writing up an animal study now, looking at different rise times effectively, and the small finding that maybe it does look like there's more distal gas distribution with a slower flow, but we're more interested in injury. But I think, yeah, theoretically you get a longer, better distribution of gas. So you expose the lung to less peak flow. So if you are really worried about rheotrauma or the risk of shearing injury, it's potentially more advantageous. No clinical trials. Okay, just remember that. But Jane in particular, when I talk to her, she says, if I have a 23, 24, 22 weeker, especially who's had poor antenatal care, I would never expose them to more than 2 to 4 litres a minute of ventilation, peak flow. So she runs their flows really low. I probably run them at half that, up again. I wouldn't want to run them at a fast rise time. With very immature babies, I tend to run like this. Where's the risk there? There's something now that I've done that's changed.
Where is the?
Sorry?
What did you ask?
I've turned my flow down, slowed the speed the lung's inflating. But that means that now the time I need needs to be longer. So do remember when you're using, if you are going to use a slower rise time, you will be needing a longer I time. Yeah. And you can see we've changed that here.
Expressions beginning before.
Exactly. And this is the other problem. If you go really, really slow in your flow and have a slow rise time, the baby has to work harder to get the breath in. So there's going to be a sweet balance point between that. So if you are going to go very slow, and we do that here, now you can see that our rise time's gone right down, and we've got a very smooth, flat curved wave. The baby's going to have to work harder during inflation. So if you're seeing an increased work of breathing, then you need to go back again. This is something I've done occasionally as well if I'm in PSV, which, as you said, is a mode where on PTV we're triggering inflation. On SIMV we trigger inflation, but we don't trigger expiration. So our I time is always fixed, even if the baby wants a shorter I time. And most babies, this is actually a quite nice wave, you lose, see how we lose that little curve you get here? When you're on synchronized ventilation, you've got to set your I time just so you get that nice straight line coming down, or it should be angled. You don't get that curve out because the baby's sucking is moving chest wall. So you set your I time separately.
I didn't get that. Can you explain it again?
Here, the patient has actively pulled the chest wall down. So, and then they recoil, and you've got a lot more. The recoil's different, so you don't get the classic zero flow because you transition from inspiration to expiration much quicker because you're snapping. You've got two different components to your pump. So I tend to set, if you get something like this, that's perfect. But if not, I'm just wanting to see a line that is not quite straight, it changes sign. And then your I time's probably okay. If your I time's too short, it goes straight down. And you can see that just it's subtly changing here. But in pressure support, what you're now doing is you're also asking it to trigger expiration, aren't you? So here, if I breathe really fast, it will start to decrease the I time, which you can see on the ventilator here. The I time's changing. And then when I go to apnea, you can see it's going back to just that fixed 0.4, so the maximum I time. And you set a maximum one to stop the baby going and holding their breath forever, right? But the problem on pressure support, I don't know, have you all used pressure support?
Yeah.
And what do you think?
I don't use it very frequently.
No, most people.
Not as a separate, not as a standalone.
Yeah. Do you use it?
Combine it.
Yeah, that's probably what I do as well. But the problem is you can allow hyperventilation. So now you can see I'm ventilating at an I time of 0.18 because the baby's just going, and you've taken the break away from the I time, right? So how do you, there is, generally, most people just turn the baby off pressure support if you want to keep them on, you can use your rise time as a break. So if they're breathing and panting, put your rise time up really high so it slows it down, and actually you're trying to impose a bit of work of breathing to try to slow down their respiratory rate. Does that make sense? But
what about the
it's
trigger
really
sensitivity?
complicated. Yeah.
It's not making sense to me. I want
Okay.
you to go back to
Okay.
that.
So you can put the trigger up as well, but you have to be really careful. If you put the trigger up too high, then the baby may still pant, and then they're getting no support or less support, so they actually work harder. So generally when they're panting, they're generating very fast flows.
So you're talking about
Sorry. Yeah.
just as a flow sensor, separate mode or SIMV plus?
No, in pressure support only.
Pressure
Not in the. I'll show you the second one here. So they're breathing very fast here. They're puffing away and generating high flows, right? And generally they're breathing fast, but there's no there's no work of breathing on the system because they're able to do it, right? So if you slow the gas flow down, then you're relatively breast starving them during each inflation, and you're increasing their imposed work of breathing. So they're going to have to work a bit harder. So as a consequence, some babies will slow down their rate. So you're kind of pushing them into a slower rate by making it harder for them to breathe a little bit because they're doing it too effectively. Honestly, though, most people just take your PSC off.
So usually we start thinking of expiratory synchrony predominantly with the meconiums.
Yeah.
Because they're going so fast
Yeah.
and they're all big babies. So most of the things keep going out of control.
So often with the meconium ones, we sedate them down in acute lung disease. If not, make them apneic, we sedate them enough to make sure they're really comfortable because they get really nasty pulmonary hypertension and lots of shunts. And if you're agitated, your shunts get worse. So if we would sedate them with analgesia, and then if they're still shunting and deoxygenate, we will muscle relax them in acute care just to get them through. But we also flick them to high frequency quite quickly and treat their pulmonary hypertension. Yeah. And they puff though for ages, don't they? So you have to warn the parents afterwards that they're tachypneic for often 2 to 3 months after their acute disease. Yeah. Same with the CDH babies. You have to warn the parents they're going to be tachypneic for months. Yeah, or else they sort of people get anxious. Yeah. So in India, every time I've come, people talk about SIMV with pressure support.
SIMV is favorite mode here.
So I think, and in Australia, most places don't do this much. We do. In our unit, we use this mode and PTV the most commonly. I think it depends on what disease you're treating, right? If you've got acute lung disease, like meconium or RHMD, you want to treat every inflation with the same support, right? And make it easier on PTV. Because on PTV you don't have multiple things, so all of these things go away, right? You just set your TI, your backup rate, your tidal volume, your PEEP and your maximum PEEP, and you let the baby work away. On SIMV with pressure support, you're setting the SIMV settings and the pressure support settings. So if you've got acute lung disease, it's unlikely you need them to be different. So we tend to use this as a weaning tool in term babies. Because I find in preterm babies, we just leave them on PTV with volume guarantee and they just auto-wean quite quickly and then you extubate them. But in term babies, sometimes you can't extubate them because they don't have lung disease, they have opiates or surgical wound or whatever, some other problem, and they tend to actually get overventilated, don't they, on PTV? So that's probably why you use it too, is at that setting, those babies that have good CO2 clearance.
Yes. Normal lung.
And then you're setting your SIV rate, aren't you, as your weaning rate. And what are you doing with the pressure support? What's the purpose there? Why are you using pressure support?
To support the spontaneous.
But you're doing that with your SIV.
But you're fixing your rate and you're generally keeping a lower rate.
So why not put them on pressure support for every breath?
That's just you need a confidence level to do that.
Some
Some babies it's probably easier.
Yeah. So I would say that where I use it is where you have a baby with good CO2 clearance, right? And you're using it as a weaning tool. You're going to use your SIV rate. Your SIV component of it is the bit that's controlling your gas exchange. So if your CO2 is too high, you'll drop your tidal volume or you'll drop your rate. And you'll do that on the SIV component. And it may be that you need to go to a very low rate, like 20 breaths a minute, right? Or 30 breaths a minute, because their CO2 is normal, but they're breathing at 60 breaths a minute. So you're not supporting every breath then, right? So you're asking the baby to work harder for all the other breaths. So if you turn this off, you can see the baby's getting the 20 supported breaths. For every other breath, the baby is having to generate all of the effort themselves against the circuit and the gas flow. So it's harder than if they were extubated. So what pressure support in this mode is designed to do is to offload the work of breathing from the circuit. And generally, if you look at the data from the Miami group in Florida, you need a pressure support of about 3 to 6 centimetres of water above peak to offload the work of breathing. But you're not aiming to generate any tidal ventilation with that. The baby's still doing all the tidal ventilation in the pressure support breath. So you're just doing it as a comfort work of breathing tool. So if our PEEP is 6, then we want our pressure support at about probably 9 or 10, right? And here you can see we're getting that little pressure wave that's occurring, and then every so often you get the big SIV rate.
This one is a PIP of the pressure support.
Yeah, exactly. It's good for
it's
the...
not like in an adult ventilator where it says pressure support is the value above peak. Yeah.
So it's good for the improving lung or the weaning lung, because if you're needing to give high pressure support, it's as good as PTV then, isn't it?
Yeah, if you're using high pressure support,
Then
just have it on
put it as
PTV.
PTV.
Yeah. There's a lot less numbers. But it does give you the option to have a baby. So some of our term babies who are post-surgical, we can't extubate because they're on too much opiates, and they're over-ventilated. You can just have them on a rate of 10 with pressure support, and they're often very comfortable. You wouldn't want to have them on a rate of 10 without it, because they'd be getting all that ET, CPAP and effort, and then they'll just sit there until you extubate. But obviously, the better thing is just to extubate them if you can. So we tend to only use it, if we've got acute lung disease, we use PTV all the time, and then without it, we go to this when we're using it to wean slowly off other. Does that make sense? What else can we talk about this one? Sorry? Asynchrony.
It's maybe difficult to show.
A hard one.
It's difficult to show.
Yeah, I think it's hard to show. I mean, it's easy to see what asynchronous is. That's sort of an asynchronous. Sorry? Trying to find an asynchronous sort of pattern. I'm not really sure we're going to be able to demonstrate asynchrony easily. Asynchrony is often around patient comfort, patient position, and then thinking about our trigger and our rise time afterwards. Any other questions? What else would you like to know? Especially for the fellows. The lungs there if you want to play with that too.
So I have a question. In non-invasive mode, in CPAP mode in this center, there is something called as CPAP pressure on the non-invasive.
Yep, which one?
So, yeah, so.
It's because
Yeah.
here, if you go to the alarms, you will have apnea time.
So
If your ventilator is delivering the CPAP, But if you turn this one on, the ventilator will push some stimulation brake. Like
And I TS kind of thing on that.
so, and those ones, the PIP is for your stimulation brake.
But normally it would only do that in certain situations. Like we never turn the stimulation on, we just have them on backup. We generally have them on CPAP. Otherwise we put them on NIPPV.
Oh yeah, NIPP.
You put them in NIPP.
Well, we would just,
changing to that.
if we want backup rest, we just put them on this.
Yes, but this one is just in case of apnea.
Yeah.
So it will kick in only if you have an apnea.
I'll just show non-invasive triggering. The trigger is here and it's in as a percentage. I always start high and then I don't start low, I then wean it down if they're overly triggering. And here it's probably overly triggering, right?
And I think it's recoil when it recoils.
So, because clearly we're apneic. So you might want to turn the trigger down in this case. But I think every time I've used it, I've left them at a high trigger.
Okay, I'll show you with.
Do you want a non-recoil one?
No, I just need a match. Whatever.
What size do you
have?
And then high frequency. In this situation, it's just high frequency because we've got an ET tube, right? So you can see the settings are exactly the same, but in non-invasive you'll have a big leak. You do it if you want. You're apneic now, aren't you? Are you trying to trigger? I'll put the sensitivity up. See, I asked, no unit uses synchronised NIPP. Everyone uses unsynchronised. Which is interesting because a lot of the conference I go to, everyone says, oh, we always synchronise. But everyone, I don't know, no one seems to.
Actually, if it's available, use only the synchronized one.
But no, I don't know anyone that is.
Who has this one? So can you synchronize one?
In the UK, were they synchronising?
I think they were on the Sophie.
Yeah?
They've just moved to SL, so I don't.
No, but they all have synchronisation.
Yeah.
Yeah, but some are not.
As easy to see, like the Fabian, there's different ones
No,
that
it's a
synchronize.
question that it's.
Ah,
It says that it's synchronized, but actually it doesn't do it very well. But if you have the SLE, you should try because the people using the synchronized one, the feedback are very positive. So give a try. I would give a try at least.
It's really interesting. No one seems to synchronise, even though we talk about it, right?
I think they were using. Because Evina had moved to this and they were all using the synchronized one.
Yeah.
Because they just bought new machines. I'm sure that they have all of that.
I had some of your colleagues from Australia said that it was very good.
Who? Not in Melbourne.
I don't know.
There was no one in Melbourne synchronising with that asked.
So why are they not started?
I don't know. I asked, and then I said to them at the perinatal, why are you not? Because you're meant to be like the evidence-based people. And they said, I don't know.
Maybe what is available, what they have is not doing it properly.
Yeah.
When the extubator will be from ventilation, say like HFD baby and in 2-3 days time we have extubate also. what settings do you put initially on the NIVs with the same settings you're using the conventional ventilator or to give more pressure?
What would you do? Because the answer is there's no right or wrong answer, right? So, because they're not the same, it depends what your settings are. And I think it depends on why you think they're going to fail. Because remember, with NIPPV, you've got a big leak. So your pressure delivery is going to be very variable. And that pressure delivery is variable in peak and PIP, not just PIP. People focus on the PIP. So you could have a peak that's varying a lot, you could have a PIP that's varying a lot. So I probably, if you look at most of the trials, they've used NIPPV of sort of 10 to 15 on 5 to 8 generally. I think that's not unreasonable for extubation failure, although you could ask yourself why not just extubate them to a CPAP of 9, but that's probably the same thing. But I think if you've got acute lung disease, I would use a higher PIP. And then I'd watch the patient and see whether the NIPPV is correlating to chest wall rise or not. Because the benefit may not be from tidal ventilation improvement from NIPPV, it may be upper airway tone. So I'd look at chest wall rise and look at whether do I want chest wall rise from my NIPPV? Am I comfortable to increase it again? Do I have a big mouth leak? That sort of stuff. But I probably avoid using PIPs above 20 in most babies. So because I think then probably you've either just got a huge gas leak or you've got a baby that wasn't ready to extubate. And I generally use rates of sort of 20 to 30 to start with, sometimes higher, like 40, and then wean them down if it's for post-extubation failure. But again, if you look at the trials, most use a much lower rate, like 10 to 20. So, but I tend to start higher and then wean down. But I'm not afraid to using higher peaks, so I guess that's probably more comfortable. It depends on the size of the baby. Yeah. So the bigger baby is probably 0.5, 0.6, and the smaller baby is a smaller eye time.
I think the TI in the study, what it was shown is that when you have the two branches like that, the TI site is lower than when you have the low path with one branch which works differently. And the pressure that they set is also lower because they can't go higher. It's limited to the galley. So the setting might be slightly different depending on the kind of.
And everyone is having different
What's your weaning, readiness for weaning? What do you follow? There are different ways, like the PEEP trial, ET PEEP trial, or turning piece.
Are they breathing?
Yeah.
Do they have good gas exchange?
Yeah.
Is my mean airway pressure low? So for me, generally for a preterm baby, if they're on a PIP of 10 to 12, and they've got for most of our unit, our babies are on PEEPs of 8, and then some of them 6, so we use a bit higher PEEPs. That means they're using very little delta P, so they're probably not needing the tidal ventilation to extubate. And is their FO2 in a range that I'll extubate for, and also give me enough buffer for it to go up. If they're a term baby, I'm going to offered a PIP of 15 will be enough to extubate a baby, right? So I'm looking at the numbers, and I do the a CPAP trial. Yeah, but again, I'm from Melbourne where we sort of did a lot of them anyway, so I do put them onto CPAP for ET CPAP for 3 minutes, watch the saturations. You could technically put them on pressure support and turn their pressure support. Yeah. And if they're on the oscillator, on this machine, I turn the delta P down to about 3 or 4 centimetres of water, and that's just CPAP. If they're on the Sensomedics, I just press the oscillation button off. Yeah. Oh, do you? On the 5000 you don't? Yeah. I just turn it down to 3 or 4 centimetres.
So different ways that you can try either CPAP or.
But how long does it pause for?
Give some breaks. Because if you don't give some breaks,
no, I wouldn't pause it for minutes. No, 3 to 4 minutes. So I just turn this down. So, and then I watch what they do and watch their breathing and extubate.
I mean, generally you get a sense, but certain babies you ventilate for a few days, you want to make sure 100% they will be extubated.
But it doesn't make sure 100%.
Yeah, exactly.
And
They sometimes fail here and then they do well.
Yeah.
Or the other way around.
That paper of Omar's was like 83 or something %, but then the subsequent studies show, some of them show no difference over just extubating without it.
Sick kids also used to have argument. The artists will come, oh, he's failed CPAP. And I'm like, no, forget it, just extubate and then they do fine. Like, sometimes they struggle through the eating,
And sometimes they pass and then they fail expression, right? So, but remember, you've got other things going on, right? Suction, secretion, comfort, feed tolerance, reflux. We get a lot of chronic babies who fail because of reflux, and then we put a jejunal tube in and they extubate beautifully, right? So, yeah. Sometimes. In our unit we give a lot of them because we have a lot of chronically ventilated babies and a lot of airway babies. So all babies with airway disease, we always give steroids. So our babies having maxillofacial ENT surgery always do. And then we would do it on a case-by-case basis for other babies. But generally babies who've been ventilated for more than about 5 or 6 days, we would give some steroids for. And it also depends on what their leak's been as well. If they've had an 80% leak with an appropriate sized tube, then I'm probably not going to worry too much about steroids. Yeah.
More than 5 to 7 days.
5
to 7 days of ventilation, I think.
So it's usually just 2 days, 2 to 3 days. It depends. If they're an ENT baby, often a lot more than that because we're so cautious. Is that the same? Is that your practice as well?
Yeah.
For steroids?
Just for extubation?
Yeah.
I think we'll probably wait for longer, not 5 to 7 days. I think their threshold is much
It
higher.
depends, though, I think, on the leak as well and what their risk of failure is, right? Yeah.
Especially if they failed before and if ENT has said, then they would otherwise.
We use a lot more steroids in our unit than the perinatal unit next door because I think we've got a bias because we have so many airway babies that we just tend to get anxious about it. Yeah. But we use a lot more opiates as well. So. Yeah. The 0.25 per kilo dexamethasone.
150 mics, I think.
Yeah.
250 actually.
The French.
250, fraction says 250 mics, High.
You also need to understand that when you become a consultant, you don't know the doses.
You don't know the doses, I know.
I do not know the doses of these drugs. I know the doses of fellow and say, I want peri-extubation. And then also we have an EMR. Do you have an EMR?
No.
We have like Epic or Cerner or whatever you use. Once you've got that, you definitely know none of the doses anymore because when you go and write dexamethasone on ours, it says indication, extubation, then it says here is the dose. Is that correct? You go click and it goes prescribed.
This is the Vadia unit.
Yeah.
The biggest unit which I was.
So,
outbound unit we are using more common.
Yeah.
That's a typical population.
And we use a lot of steroids for chronic lung disease. A lot. And I think more and more you realise you don't follow the protocols.
Yeah. You're stuck. Steroid is the help.
How early do you start? Or how late?
As late as possible. Yeah, so we don't follow. We've got one unit in Melbourne that is using early hydrocortisone, which I don't think works. In under 10 days, in under 7 to 10 days. I don't think it works personally because all those babies come on hydrocortisone and they look awful. And then we wouldn't use it before the 14-day mark, 10 to 14-day mark under the sort of meta-analysis. And then the answer is as late as possible. But once you start, unless they extubate properly, yeah. And I think we've got one of our fellows did a study looking at the Royal Women's, Royal Melbourne, Royal Children's steroid practices, and she's been trying to get it published and struggling. And I think more than half of our babies don't get DART or Cummings, they get something else. So even though we only have 2 protocols, we have DART, we only use Cummings generally for the sickest babies after they've had a couple of failed in the course of DART, and only with parental consent now. at least, I can't remember the exact numbers, but it was at least half of the babies prescribed steroids were getting an out of protocol regime.
More or less.
Which generally it means that they start on DART and people are reluctant to wean it. So they take, longer on DART than the prescribed course. Yeah. So. Oh, and of course we have the PLUS trial has finished recruiting.
Which one?
That's the Brett Manley's study, which is budesonide given with surfactant.
Surfactant mixture. Okay.
Which comes from the Taiwanese group from Ye's study, Ye's practice, and Ye showed that data at TAS this year of a randomised controlled trial, their second trial, and huge reductions in chronic lung disease. So again, but it was very hard. There was 100% parental compliance, which is a little bit hard to believe around how informed the consent was. But they finished recruiting PLUS, and that was 1,000 babies, and I know they're showing it at Hot Topics,
December,
in Washington in December. So that trial and that finished in about March-ish, so they must be, I know they're refining the data, so by the end of the year we'll know more about it, but it's still the first big trial, and there's a US trial called the BEEP or something trial, which is the same as PLUS. It's a budesonide surfactant vector trial. The same
one
thing.
came, I think, recently. I saw one paper that combined.
I don't think there's been a big clinical trial, except for the Ye one.
Yeah, there is. Because I presented that.
Oh, there was a small one, I think, wasn't
there
there?
was.
Yeah.
Because I presented, I could present.
What is the level of BPD
I don't know.
Because the doctor was telling me that there is a very low amount of BPD similar to Japan.
I don't know. Yeah, I think so. So that's probably one of the new. That trial, I think, will be important when it comes out because it may alter practice. Although I suspect people want to wait for the American trial as well, which will still be 4 years away. But the only difficulty was it is currently off-label. If you use Curacif here, if you read Curacif's guidelines, it says it can't be mixed with anything else. So the trial had to be done as an off-label pharmaceutical trial with Curacif helping them. So it would be, if they find a positive result, I think they'll have to see, you'll either have to get local regulatory approval to go off-label, or Curacif will have to change. Yeah.
You might have just written that one for that first to make sure that they are not liable.
The other issue with that trial is that if I remember, the PLUS protocol, I think allows up to 3 doses of surfactant because the first dose didn't have to be randomised because they had prospective consent. So it'll be interesting to see how many babies have got 3 versus 2 doses as well. Yeah, it'll be interesting to know.
Yeah, I read about surfactant.
Well, I think it's 5 o'clock, so it's probably time to wrap up because I'm feeling pretty tired anyway. No, that's erection.
So much intensive work goes on.
Oh, that's okay.
That's okay, yeah, but there was, Sally, I think. Cali, I think.
Callie? Oh, yeah.
Cali.
Let's have a look.
Something. Yeah, sorry.
Well, thank you for staying so long.
Oh, yeah.
Are you happy that we wrap up now?
Yes, very good.
Tea's there. It's a long session, so we have a tea break or a final
tea break
with some snacks. So please
Sure.
have it.
Thank you for arranging.
Stuff.
Very nice.
Thank you very
Feeling
much.
stuffed.
Thank you for staying so long. It's a very long day.
Thank you so much for your excellent talks.
Yeah.
We wish we could have you longer. Another day, I mean, not this evening.
Well, hopefully I can come back to India.
You should.
Yes.
You should.
It's been, this last time I was here was 2018.
Yes.
So,
COVID came.
then there, well, it was very, it doesn't, COVID
After
changed
COVID,
it.
this is just first time we started this kind of education.
That's why I was trying to get to the. If you would have more time yesterday, we would have gone to the units also. Yeah. Maybe we should plan.
Maybe next time
Maybe next
we'll
time
plan some more
we'll
extra
plan your
time.
program better.
Yeah, we'll plan a
your
program.
We've been,
No free time.
No free time.
Let him fund the program,
Let
but
him
we'll
fund.
plan it.
Let me one day for us. We'll plan that one day.
University or medical college so that we can cover more
More trainees.
Yeah, that's
Aspiring.
right. 2 units are there.
And
no,
your
idea
hospital
of
will be open.
those babies there.
Yes.
We have 200 babies.
so next time I think that
we
would be
can.
much better
Yes,
because
yes.
that experience sharing and education
Yes.
that is the best part I think.
But you don't need me to come. You guys know all of this already.
No, don't say that.
No, I was like
There
listening
are
to all
always
here. You're
small
all very
things
good. Do your own
which
training.
will make a difference to patient management.
Do
I
your
Small
own
think
things
training.
which
experience sharing is
which we
really
tend
good.
to
at that.
ignore generally, Okay,
Lots of
patient is
workshops.
doing well, okay, move on. Let's see the next baby. So these sessions,
I think such kind of
make more,
sessions, these kind of
meaningful
sessions, they look very
We're
basic
doing workshops,
sessions,
bedside,
but
I
I
think
there is
more
more
people
clarity
do
during
more
these
bedside.
sessions. And this will definitely help treating the babies.
we should plan.
Okay.
We'll be in touch, Dr.
Yeah.
Swati, definitely.
Do you do lung ultrasound?
Sorry?
Yeah.
Do you do lung ultrasound?
Yes. They're
Doing a project on that.
Do you like it? Or you like it? Yeah, you're doing it. Yeah. So do you think it's something you'll be doing routinely all the
I
time?
mean, we're trying to get, it's still not become a routine, but I think that's what we're trying to implement as a part of study. Acute iteration,
Yeah.
pneumothorax, and RDS again, you can always decide based on X-ray, but having some scoring, it adds on to
Yeah.
the thing.
Yeah. Good.
It's picking up slowly.
I think it's a good, same. I think it's a good thing to learn. Yeah. And it's not hard.
It's not hard, it's easy.
Yeah.
So I think Patricia is in Perth now. Like I was there in
Trisha's
Perth.
in Perth,
Yeah,
yeah.
so when she came and she started now everyone after echo they finish quickly do lung ultrasound also.
Yeah.
Now they're saying they're picking up a lot of things. So it's actually the culture change in the unit. Should get into that routine of doing routinely. Echo tech become a culture now.
Yeah.
Lung ultrasound also has to. And doesn't take time, it's 5 minutes.
No. Good. Okay.
Alright.
Pack up.
Let's have a happy tea and
Yeah.
please.
So your best friend is basically insisting you can extend your stay.
Yes.
Not this trip.
Not this time. Next time.
I'm on board service on Monday. I think if I didn't show up, my colleagues would kill me.
Definitely.
Yeah.
In coming few months or a year.
So I'm on board service. We've had to change our service because of the demand. Because we have so few nurses, we're often really tight for access. So we've had to introduce a third consultant who's just does referrals and bed management now. So there's a clinical care was getting impacted by the staffing issues. So I've got a week of discharging patients and arguing over
Bed
admissions to go to. And there's no way my colleagues will let me get out of that because no one else wants to. Yeah. So.
That was good. We spent a lot of time, I think, last 48 hours.
Since last 3 months, he was quite excited to meet you.
Well, we were fellow for ages,
13 years now. We met in Greece.
Recently, in our old hospital. You were in our old hospital.
Our old hospital.
Not
Before
the
moving
new
to,
one.
not the new one. RCH, yeah. It was just moving that year, 2011.
It's very similar design to your new hospital, the MRI one. Yeah. Just a bit bigger.
Bigger, yeah. RCH is different.
Yeah. But
MRI has done a good job to at least give a good infrastructure. So
but we don't have much private pediatric inpatient hospital in Australia. Most private is in adult medicine. Yeah. There's no private NICU in Victoria. I don't think in any of Australia. it's a public hospital. They have private patients, but not a whole NICU that's private. Yeah. Yeah.
Right.